So, respected persons, my seniors and colleagues, so we'll quickly rush through the topic that is hyperkalemia in heart failure with reduced ejection fraction on patient with guideline-directed medical therapy. So, we'll start with a case scenario which is a 59-year-old male with a history of diabetes, hypertension, the chronic kidney disease with a creatinine of 1.6 with GFR being 49 ml per minute and was diagnosed to have heart failure with reduced ejection fraction with an EF of 35. He was started on guideline-directed medical therapy with beta blockers, mineralocorticoid receptor antagonists, ARNI and SGLT2 inhibitors. So after 2 weeks on follow-up, his creatinine rose from 1.6 to 1.9, his GFR being 40 ml per minute, and his BP 100 by 60, and his potassium rose from normal to 5.8. So what's the plan and how to titrate? Because in heart failure with reduced ejection fraction, nothing comes as alone. Usually you have to start in a patient with a CKD. Along with hyperkalemia, there is a slight decrease in the eGFR. So before going how to plan and titrate, we'll just go through the understand the cause and risk of hyperkalemia, review the GDMT agents contributing hyperkalemia, discuss the strategies and explore the current guidelines. So as you all know, heart failure with reduced ejection fraction, EF being less than 40, we know the components of GDMT, the 4 main pillars, and it adds on with the decompensated heart failure with the digoxin as well as the variceal gout. So among this, as you can see, the AC inhibitors, the ARNI and MRAs are the culprit for most of the hyperkalemia. So you can see a patient started on heart failure with reduced ejection fraction on guideline-directed medical therapy. The hyperkalemia is a common entity and it rose to around 40%. As the definition goes, the mild is 5 to 5.5, moderate is 5.5 to 5.9, more than severe is 6. So before starting an ARNI or a MRA inhibitors, RAS inhibitors, which include both the ARNI as well as the MRA, you have to know which all patients are prone for hyperkalemia, like CKD, the risk factors, especially in subset, diabetes, older age, use of RAS inhibitors earlier for hypertension, a neoplasm or CVA, or a medical history of hyperkalemia which has been unrecognized. So once you recognize it's a true hyperkalemia after rule out hemolysis, you have to assess the severe. The next step that we all take is a ECG, whether ECG signs of hyperkalemia is there. And then we classify it as an acute, because the ECG changes and the symptoms might be acute or a chronic management. And always keep in mind that we have to keep that, avoid compromising or down titrating the GDMT whenever possible. So the acute management, when you see an ECG changes and the symptoms of the patients, you can see stabilize the myocardium with the IV calcium gluconate, shift the potassium intracellularly with the insulin glucose, beta-2 agonist, sodium bicarbonate, remove the potassium with loop diuretics, potassium binders and hemodialysis. We'll be concentrating more because initially once we started, then on follow-up you find the increase in creatinine as well as potassium. So here you should more concentrate on the dietary potassium restriction, where you have the more increase in the potassium in the fruits, juices as well as in the meat. Then the other important thing that you should history of the patient regarding the NSAIDs, other drugs that are the patient, and the distal diuretics, maybe the triamterene or amloride. Then optimize the diuretics, the thiazides if the volume stats permits, and the potassium binders, which is a newly FDA approved, which has been used to maintain hyperkalemia and maintain the maximum dose of GDMT. So along this it comes the FDA approved ones are patromer and sodium zirconium cyclosilicate. So what about the guidelines? So guidelines say before in AHA, ACC as well as CAC says about MRA, before less than 5 you can start the MRA. If it is between 5.5 to 6, half the dose of the MRA. And if it is more than 6, discontinue. Similarly, the RAS inhibitors, which include both, if it is more than 6, you have to discontinue, followed by careful reintroduction. So this is the latest ESC guidelines 2021, which shows acute and chronic heart failure, where you can see the RAS should be optimized when the potassium levels are less than 5. An approved potassium lower agent should be initiated as soon as the potassium level is more than 5, and then closely monitor and maintain the potassium lowering agent unless other etiology has been corrected. So when you look the numbers carefully, if it is 4.5 to 5, no issues, start, titrate, closely monitor. But once it raises to more than 5, you have to start a potassium lowering agent, and the chronic the FDA approved one is the patromer and the SZS or the sodium zirconium cyclosilicate. So in this, you initiate the treatment or you titrate it with a potassium lowering agent, and you closely monitor the potassium level, and if it comes less than 5, you can uptrate the RAS. RAS inhibitors. And if it is already on the target dose, then you have to titrate and closely monitor. And in this, it said more than 6.5, just one, more than 6.5 is the cutoff given in the ESC guidelines, which says you have to stop and you have to reassess. But when you look at the AHA guidelines, it has given only class 2B to continue the RAS inhibitors along with the potassium binders. So the therapeutic action based on both consensus, we can say 4 to 5, you can prescribe and titrate RAS inhibitors. When it is above 5 and less than 6, you have to introduce a potassium binder and carefully monitor the potassium. If it is more than 6, suspend the RAS and reassess. So earlier it always acts like when we have a CKD patient with reduced ejection fraction, you see an OPD rise in creatinine potassium, you stop the RAS inhibitors, and then reintroduction is the major difficulty. And once you stop it, the reintroduction doesn't happen, the patient doesn't get any benefit. There comes the important role of the potassium binders, where it helps in the normokalemia, RAS optimization, and reduce mortality. So a few words on the newer or FDA approved ones are the Patromer and the sodium zirconium. Patromer is a potassium binding, it is a polymer, it's potassium binding, it is orally taken and it is not systemically absorbed. It has a, fine, yeah. Okay, everyone is waiting for the, okay, fine. So for the acute action, actually sodium zirconium cyclate is used because its onset of action is just 1 hour. So revisiting our case, the increase in the creatinine being less than 30%, or the EGFR being more than 30, and the potassium is 5.8 and asymptomatic. So the options first will be to decrease the intake of the potassium and avoid the foods rich in potassium, avoid drugs which NSAIDs if at all, start on thiazide diuretics, start on potassium binders if it's available and closely monitor, and stop the MRA and restart once the potassium is less than 5. So the take home message will be the hyperkalemia is a common entity that you will be always facing in the OPD, and it is associated with the increased hospitalization and mortality. So down titration is associated with the doubling of mortality across the patient subtypes, and discontinuing RAS inhibitors should be the last resort. So consider potassium binders before dose reduction, and once you see this heart failure on this, periodic checking of potassium as well as EGFR is a must in all these patients with CKD. Thank you.